Today I want to talk about strokes. Strokes are important because they are frequently encountered by the EMS provider and are a serious source of increased mortality and morbidity in the community. Today's objective is to recognize strokes. An EMS provider needs to be skilled at recognizing strokes because that way they can make a determination of what resources they need and act appropriately to manage the stroke, thus preventing loss of brain tissue, loss of function, and loss of life. So what is a stroke? A stroke is loss of perfusion to brain tissue. Remember, perfusion is really just blood flow to the brain. When you lose blood flow to the brain, you lose the ability of cells in the brain to get oxygen, and you also lose the ability of the cells in the brain to get rid of waste products. Waste products include CO2, acid, and nitrogen. Stroke will present as a focal neurological deficit. Let's break down that word. Focal means focused, so it will be in one contained area. For instance, if my arm goes numb. Neurological, meaning that it's neurological in nature. So that means it could be a motor issue, a sensory issue, and then deficit meaning some sort of deficiency. So who gets strokes? The important thing to remember is the person who gets strokes is anyone. It's important to not forget about the pediatric patient. Pediatric strokes, while rare, are frequently misdiagnosed. The delay in diagnosis means a delay in proper treatment. With these diseases, time is tissue, so a delay in treatment means that more tissue is going to be lost, which will lead to a greater incidence of mortality and morbidity. It's also important to remember that sickle cell disease is a hypercoagulable state, so the patient will be more likely to throw clots. These clots can go to the brain. So with any patient with sickle cell disease presenting with a neurological deficit needs to be thought of as a stroke patient. Risk factors for a clot include risk factors for any general cardiovascular disease. This includes high BP, smoking, diabetes, obesity. Furthermore, if they have a history of a prior cardiovascular event that would include stroke, vascular disease, or heart disease, they're more likely then to present with another thrombus or embolus type event. Furthermore, you can have atrial fibrillation or heart failure. The reason these things represent an increased risk of stroke is because you now have blood that's not really moving forward, and stagnant blood is more prone to clotting. So in atrial fibrillation, the atria is not contracting correctly, so there's a little bit of a stagnant pool of blood in there, is more likely to clot. Heart failure is the same way. The heart is not contracting effectively, so you're getting a little bit more stagnation of the blood, causes it more likely to clot. Family history also plays a role in strokes. If a family member has had a stroke, the patient now is at an increased risk of a stroke. This can be due to many factors, including anatomical or physiological variations. Mechanical valves and valvular abnormalities can also increase your risk of stroke. Mechanical valves tend to shear red blood cells. When a red blood cell is sheared or broken, it releases chemicals. These chemicals signal to the body that there's damage. Anytime the body detects damage, it wants to then clot. Valvular abnormalities, these are scar tissue or vegetations that form on the valves. These are important because if you have scar tissue on the valves, you can then have red blood cells start to clot off of that. They serve as almost a starting point for clots to start forming because scar tissue is considered damage, and the body wants to clear that damage, so it will start to clot there. Once it's clotted there, these clots can then break off and then travel to the body. And a lot of the blood flow from the heart goes to the brain, so it's not uncommon for the clots that start in the heart can go to the brain, especially if it's a left-sided clot. If it's a left-sided valvular clot, the next step for it is the brain or the body, and a lot of the blood flow does go to the brain. So I've been kind of using the words embolism and thrombus, but let's really break those down. So at the heart of it, an embolism is a block, and a thrombus is like a dam. So the embolism blocks the blood flow, which means it traveled from somewhere else and got jammed somewhere. A thrombus is like a dam in the fact that it was built at the spot that it's now blocking or damming. A thrombus is what you consider the classical clot. This is what causes most heart attacks. Thromboembolism is what we call the embolus when it has been lodged somewhere. So remember, an embolism is a blocker, so it starts somewhere else and travels. When it stops traveling because it's now become restricted and it can't move forward anymore in a blood vessel, that's now called a thromboembolism. Most embolisms that travel to the brain and cause stroke will start in the carotids. The carotids represent a pretty good area for an atherosclerotic plaque and then also narrowing of the blood vessel to start. And when you have narrowing of the blood vessel and a plaque, you have an area for a clot to form, and that clot can then break off and travel to the brain. So my right carotid will travel to my right brain usually, and my left carotid will travel to my left brain usually. This is important to remember because on physical exam, you can listen for carotid bruits over the carotid arteries. And hearing a carotid bruit does raise your suspicion that there's narrowing in those carotids. Another place where an embolus can form is in the legs. This is called a DVT, for deep venous thrombosis. The clot will form in the leg and then break off and travel. The thing is, though, is the clot will generally travel to the right side of the heart, and from the right atrium, it will travel to the right ventricle, and from there, it'll go to the lungs. So generally, a DVT produces a pulmonary embolism and doesn't produce a stroke. It is rare, but in patients that have a PFO, which is a birth defect known as a patent foramen ovale, in a patient with a PFO, the clot can actually cross over from the right atrium and into the left atrium. From there, it'll go to the left ventricle and then out to the brain. PFO is rare in adults, and furthermore, even if you have one, it's rare for a clot to cross into the left atrium. So this generally doesn't occur, but it can be something that does happen and should be on your mind if someone does present with a history of a PFO and then also a focal neurological deficit. Other emboli that can form include foreign bodies. This is mostly due to surgical procedures or if a stent has been placed and part of the device breaks off. You can also have a fat emboli. Fat emboli come from if you break large bones like a person's femur. If a femur breaks, that fat from inside the bone can leak into the blood vessels, and then this fat can then travel up to the brain. Another type of emboli that can form is a meconium emboli. This occurs when a female has given birth to a child, and meconium slips into the female's vasculature. This meconium then goes to the brain and causes a blockage. This should be suspected in any female who has recently given birth and now presenting with a focal neurological deficit. The last emboli I want to talk about is called a septic emboli. Septic emboli occur when you have bacterial growth on the valves of the heart. These bacterial growths will then break off from the valves and travel up and become lodged in the vasculature of the brain, causing a stroke. This should be suspected in any patient who tells you that they have endocarditis, which just means bacterial infection in the endocardium, which means inner part of the heart, including the valves. When do people have stroke? Anytime blood flow to the brain is disrupted. So with that said, there's many types of strokes. One is global strokes. Global strokes really just represent a decrease in overall blood flow, which would just result in AMS, and focal neurological deficits really aren't seen. Another type of stroke is a hemorrhagic stroke. This occurs when blood vessels rupture. When a blood vessel ruptures, it does two things. The first is, if blood is leaking out the side of a blood vessel, there's no longer enough blood traveling down the blood vessel to adequately perfuse the distal sites. So you get less blood flow delivered to the point where that blood vessel was traveling to. The other issue is that blood leaking out of a blood vessel now comes in direct contact with the brain, and that is actually pro-inflammatory to the brain. It's toxic for the brain to come in direct contact with blood. The presenting signs of a hemorrhagic stroke is a horrible headache. It will sometimes be called the worst headache of their life. It can also be called thunderclap headache, meaning that it's very intense and very sudden, or being kicked in the head kind of headache. And generally, the biggest thing that you need to know is you no longer can use clot-busting drugs. We do not want to break a clot if the person is actively bleeding. The next type of stroke is an ischemic stroke. An ischemic stroke is that classic stroke where you have either the embolus that breaks off and travels to the brain and blocks blood flow, or you have that thrombus that forms up in that blood vessel causing that dam-like structure that will then prevent blood from flowing around it. This is where clot busters become crucial, because if you're able to break up that clot, you're able to restore that blood perfusion. I included a section on where the stroke occurs. I did this because while it's not super important for a paramedic to know what an MCA stroke versus a PCA stroke is, because you'll probably never be asked a question and it's not going to determine any difference in your treatment, it is important to realize that where the stroke occurs will determine what type of deficits the person does present with, and will then allow you to be better at catching the fact that this is a true stroke. The classic stroke that we're all taught in paramedic school is really just the MCA stroke, which stands for middle cerebral artery. This is that classic stroke. It's the most common because it has the most blood flow to it, and it's also the one that's fast, which stands for your face, your arm, your speech, and then the time that the stroke initially started. That point, the time point's not as important because that's going to be needed for every stroke, but that fast, that FAS, that face, arm, speech, that is the classic presentation of a middle cerebral artery stroke, and we're going to go over why that is. So the middle cerebral artery will feed this whole section of the brain. Now, middle cerebral artery stroke will not cause this entire area to go without blood flow. There's many branches to the middle cerebral artery, so you may see just this branch being the part that's affected. But the reason it's important to talk about a middle cerebral artery stroke and where it actually is at in the brain is because right here, this area right here is actually your speech centers. And this is why we say fast, face, arms, and speech, because the speech portion of the brain will be affected by a middle cerebral artery stroke. This can present in a couple ways, and I don't want to get too technical about what they're called or anything like that, but just know that they can present with a difficulty in finding the correct word, so the person may stop a lot when they talk to you and try to think about what the next word is. The other thing you can have is you can have a speech issue where they're just not making any sense, but they can produce the words correctly. Another important part of the area fed by the MCA is this area right here. This line delineates the separation of the two gyri, which are just parts of the brain that do motor and sensory. That's important to realize because you can have both motor and sensory issues. So I could have an issue where my arm can't move, which is classic, or I can also have an issue where I'm just not feeling a lot of sensation in my arm. It's also important to remember that the MCA is only feeding this part of the brain and not this part. So your MCA supplies blood to right here, and this area includes your face and your arm. So really just your upper extremity, trunk, and face are what's being fed by the motor and sensory portions of where the MCA sits. So that's why when we say face, arm, speech, it's face and arm. The next cerebral artery that can be blocked is called the posterior cerebral artery, the PCA. The PCA is going to be pretty difficult to pick up in the field. It really supplies this back area and mostly focuses on a vision area. A lot of times you'll get what they call vision centers with macula sparing. It's just that they can't really see anything to the right of their vision field, but that center part where you can actually focus on detail is preserved. That's pretty difficult to catch on. Mostly if somebody presents on a 911 call with vision issues, you should be thinking about a stroke. And the last cerebral artery is the anterior cerebral artery. And like I said before, it really just deals with the lower limb. So that anterior cerebral artery is going to be right here. And so you'll hear a lot of times somebody say like, can't move my right leg anymore. That would be more indicative of a anterior cerebral artery stroke rather than a middle cerebral artery stroke. I just want you guys to start to learn that fast is only indicative of one type of stroke, and there's many different presentations of strokes. So it's not that you guys should remember that anterior cerebral artery means leg. It's that you guys should realize if I have a focal neurological deficit where somebody says, hey, my right leg is numb and I can't really move it, well then I probably should start thinking about a stroke. Same with if somebody presents and says, hey, I'm having some vision issues that just rapidly occurred, and now I can't really see to the right side of my body, well then I should be also thinking about a stroke. So another type of stroke you can have is a brainstem stroke. The brainstem sits right underneath the cerebrum, and then it sits anterior or in front of the cerebellum. Brainstem is really where your cranial nerves come from. The cranial nerves are the nerves that come straight from the brain and don't pass through the spinal cord. Cranial nerve 1 is responsible for smell. Cranial nerve 2 is responsible for sight. Cranial nerves 3, 4, and 6 is responsible for eye movement. Cranial nerve 5 is responsible for face sensation and chewing. Cranial nerve 7 is responsible for facial expressions. Cranial nerve 8 is responsible for both hearing and balance. Cranial nerve 9 is what we call the glossopharyngeal nerve. It does some stuff with some autonomics, and it's also part of the swallowing mechanism. Cranial nerve 10 is your vagus nerve. We all know about the vagal nerve and kind of vagal nerve stimulation and how it can cause bradycardia. That's your main parasympathetic nervous system that exits out of the brain. Cranial nerve 11 is your shoulder and neck. It allows you to shrug your shoulders and turn your neck. And then cranial nerve 12 is the musculature of the tongue, which allows you to protrude your tongue forward and backwards. The way I think about brainstem strokes is they tend to have weird signs and symptoms. There tends to be an issue with face movement and sensation, but one of the biggest things is they'll do what they call crossed symptoms. So you'll have a deficiency on the left side of the face and then deficiencies on the right side of the body. Some specific issues, they can have problems swallowing because of the glossopharyngeal nerve involvement and then the tongue involvement and a few others. They'll also have issues with eye movement because 3, 4, and 6 all deal with eye movement. They may have issues with balance because cranial nerve 8 deals with balance, and they can also have issues with hearing because, again, cranial nerve 8. One of the scarier things about a brainstem stroke is you can get what they call locked-in syndrome, in which case the patient is fully conscious, but they can do no muscle movement, and the only muscle that they can actually move is they can move their eyes vertically. They cannot do anything else. I do want to touch on Bell's palsy versus stroke. So Bell's palsy is a facial paralysis that mimics stroke-like symptoms. Uh, you'll see in both conditions, you'll see facial droop and you'll see an inability to close the eyelid, and you'll see the loss of some of the wrinkles on the affected side of the face. The main difference with Bell's palsy, if you ask someone to furrow their brow and they have a stroke, you'll actually see that the brow does not have any asymmetry. They can furrow both sides of their face, which in Bell's palsy, they'll only be able to furrow one side. So for instance, if I have this patient right here and I tell him to furrow his brow, you'll see actually a clear delineation where this side, there will be no wrinkles formed here because he cannot furrow his brow. On this patient who's having a true stroke, when you ask him to furrow his brow, you'll actually still see wrinkles all the way across his forehead. Not to get too much into the anatomy here, but in a true stroke, you lose this part of the brain, which gives you the inability to send signals down to this part of the face. But this part of the brain actually controls this side. You get double innervation, so this part and this part of the brain both feed the top of the face. And in a Bell's palsy, the lesion is actually more here, so you'll get no nerve conduction down. Whereas with a stroke, if this part is damaged, you can still get signals coming down from here. So what is the treatment for strokes? So most importantly, the biggest thing that I want you to take away from this is just, can you answer the question, is this person having a stroke? Because if they're having a stroke, you need to transport them, and more importantly, you need to transport them to the correct facility. If you have a stroke center that can get that patient and provide proper treatment, that's really where this person needs. This person is going to need special resources to manage and deal with this stroke. On top of that, provide O2. That's good advice for really anything, any medical condition where you think that there's an issue with oxygenation and perfusion. In this case, there is a perfusion issue, so we need to provide oxygen to help boost that perfusion. Generally with a stroke, you'll hear the terms infarct, and then sometimes you'll hear the term Penumbra. The Penumbra is basically just the area that's damaged but not actually dead yet, and so providing high flow oxygen can actually save that area until we can reperfuse it. The next thing is going to be to treat the ABCs. This is important in any medical setting. In strokes, you need to really watch out for the fact that if you take out the vagal nerve or the phrenic nerve or anything like that, you can decrease the ability for the lungs to expand. You may knock out the diaphragm. You can have some of these issues. So you have to really be cognizant of the fact of, are they maintaining their airway? Is there any vagal nerve issues? Vagal nerve issues, if you knock out vagal nerve to the heart, you can actually get an increase in heart rate with tachycardia. So just make sure that you're maintaining the airway, the breathing, and the circulation. Next, you may actually be able to give aspirin. Aspirin is an antiplatelet, so it allows the red blood cells to kind of get around some of the clots. So if you have a clot that hasn't completely closed off, so you're still getting some blood flow through, giving aspirin may prevent the red blood cells from aggregating there and really blocking off that section, which can really allow some minimal blood flow through. Most likely, you would have to ask your medical director if that's appropriate to give aspirin in this case. So it's going to be based on your SMOs and online medical direction. The last thing I want to talk about is I want to talk about the difference between the Infarct and the Penumbra. Earlier in the video, I said the term Penumbra. This is incorrect. It's actually pronounced Penumbra. So in this example, I'm going to use a red dot. That's going to indicate the cells that are infarcted. These cells have been deprived of oxygen due to the lack of perfusion, and these cells have now undergone cellular death. There is no recouping of these cells. I'm going to use this red shading around the infarct. This is going to represent the Penumbra. The Penumbra represents the cells that have been shocked by the lack of perfusion and are undergoing an issue with function, but they still are viable. And upon reperfusion, that is going to be when these cells regain function. This is where the phrase time is tissue comes into play, because the ratio of the penumbra to infarct is going to be set by which cerebral vasculature is being deficient in delivering blood flow. So the penumbra represents the overall issue with perfusion, and the infarct represents the area that has gone without perfusion the longest, and so has experienced cellular death. So as we have a delay in treatment and a delay in reperfusion, our infarct is going to grow in relation to our penumbra. So upon reperfusion, the penumbra will regain function, and this is what we're really targeting with in our treatments for reperfusion. This is the area that's going to be protected by getting them high flow O2 on the ambulance, and could also be protected with the administration of aspirin. So due to the fact that the brain is going to experience some cell death, you will have deficiencies. The amazing thing, though, about the brain is its neuroplasticity. All this means is that the brain's able to rework connections, so other areas can make up for the losses of certain areas, and small strokes can be relatively well compensated for by other areas of the brain. This means that a stroke has a relatively good prognosis, especially if the person is well supported with physical, occupational, and speech therapy. Well, thanks everyone for listening. That's going to do it for this video on strokes. Again, the most important thing to take away from this video for the EMS provider is just to be able to recognize that a stroke is occurring and then get them to the right facility that can handle that stroke. Again, thanks for listening, and I hope everyone has a great day.
Thank you guys so much for watching, and a big thank you goes out to Chris Wolz, who put together this entire video about strokes. It is jam-packed full of such valuable information for the current EMS provider. He is actually a former firefighter paramedic, still holds all of his licenses, and is finishing up medical school right now. Thank you again, Chris. I really appreciate it, and I hope you guys learned something today, and I'll see you next time. Bye!